So, welcome everyone. Good evening, or good afternoon, or even good morning, wherever you may be. Thank you for being here. Before we begin, I just would like to acknowledge that everybody can see and hear well. So, in order to also check the chat box, please reply that you can hear and see well so that we can start. Thank you. And I will very much like to know where you are located, where your practice is located. Thank you. Good evening. Qatar. Hello. So we will start. Hello from Poland, Ukraine, Timișoara, Romania, Germany, Portugal, Lisbon, Bulgaria, Hungary. It's going so quick, I cannot even read everything. Abu Dhabi, Moldova, Estonia, Morocco, Germany again, Saudi Arabia, Italy, Kuwait, Seoul, Lebanon, Manchester, Jordan, Pakistan. So glad you are here. Hello, Belgium, Kurdistan. Hello, everybody. So make sure that you also post anything you would like to ask or any comments you have. Make sure you post them in the chat. At the end of this hour, we will spend together, another half an hour to answer some of the questions. But nevertheless, we will collect all comments and all questions and try to answer them after that in the WhatsApp group you have joined. In order for everybody to get his or her answers. So with no further ado, let's start. I will just have a quick check with the technical team and then we can start. So it seems that there are quite a lot of people still in the waiting room waiting to be admitted. So the technical team is doing its best to do this as quick as possible. So I would like to wait another 2 minutes so that all colleagues can join. So in the meantime, I am reading your origin and where you're located. Nevertheless, you may also use the Q&A box also for placing your questions. Q&A, you have that at the bottom bar. You have chat and Q&A. So you are welcome to post your questions in the Q&A as well. Hello from Romania, Bucharest. Hello, my dear colleagues, from everywhere in the world. And I'm not sure if all of you are gynecologists or what other specialty you have. Maybe you are endocrinologists or maybe you are family doctors, because I think this field of hormone therapy is adapted for more specialties than we think. So not only gynecologists, but only, like I said, I think endocrinologists and family practitioners, internal medicine as well can safely prescribe hormones. So OBGYN, okay. Where I am from, I will let you know. Right now, I'm in my clinic in Bucharest. Nevertheless, I am commuting between Bucharest in Romania and Zurich in Switzerland, where I do have a clinic as well. So, but right now I am in Bucharest. OBGYN, endocrinologist. Very nice. So I'm very glad. So please let me know if you can see my screen, because I would like to start. Macedonia, very good. So cardiologist, internal medicine, well, that's very interesting. So as a cardiologist, would you like to start prescribing hormone therapy or just being aware of what is up to date and encourage your patients to pursue the hormone therapy maybe? women's health consultant. Well, it's an interesting profession. Maybe you can tell us more about what you are doing in women's health counseling. Very interesting. Also, I think this is a field which can benefit from knowledge regarding hormone therapy and in the field of HRT. So, dear colleagues, if you can see my screen, which I have already shared, I will welcome you again and thank you for being here. But and before I begin, I just want to acknowledge, like I said, that many of you are joining from different countries and different medical systems, and some of you are meeting me for the first time tonight. My name is Dr. Raluca Hera. I'm an OBGYN myself. I am a European Union and Swiss board certified. I have a PhD from a technical university in Munich, Germany. And my current clinical work is focused on women's hormone therapy, safety, and longevity medicine, besides aesthetic gynecology. And I practice, like I said, in Bucharest and in Zurich as well. So what I want to offer
Sorry,
you
Dr.
tonight.
Raluca. Sorry, I'm stopping you. We can't see you anymore. And
You can see my screen.
no, you and your screen, we cannot see you.
Oh, okay.
Can you
Well,
just turn
let's
off
see
the
what.
camera and turn it on?
Sure.
Let's see if
So you can hear, but you cannot see.
exactly, yeah.
Uh-huh. Let's. Okay. So no.
Let's try again.
Because I can see my screen.
Okay.
So you cannot see now?
No, we can see. Okay. Perfect. We probably see.
Now my camera is on. Can you see? Can you see my screen? So my first slide with the title, can you see it? No. Yes. No. So not anymore. Yes. So there are different answers. It's very
Just a
weird.
second. Just a
Yeah.
second.
Yeah. Sorry about that. We see the slides, so we can see the HRT fundamentals in women on the screen. So obviously the screen is because you don't have to see me, but now I have shared my screen, so normally you should see my screen right now. So the first slide.
Yeah. The best thing to do, just exit and come back, and I will give you access.
Okay.
Okay. Yeah. Okay. Let's see. Now it's working. We can see you.
Perfect.
All
Okay.
right.
Hello, everybody again. Now I will share my screen again, right?
Yeah. Okay. Perfect.
Is it okay now?
Yeah, it's working.
Perfect. Okay, thank you. So, but you could hear what everything what I said, right?
Yeah.
Need to repeat what I said. It was actually the same slide. This was the slide I was talking about the subject of tonight, and it was understandable, right?
Yeah.
Okay. So, I was talking about what I would like to offer you tonight. In this 1 hour, we would like to speak it's not a simplified talk about hormones. It's a structured clinical way of thinking about HRT, because obviously about hormones you can speak for days. So I would like to present you my concept, my clinical way of thinking about HRT, one that is safer, more precise, and much more relevant to the long-term future of your patients. And I want to begin not necessarily with theory, but I want to expose you a scenario. To picture a patient you might have already seen in your office. And I am seeing that very often. Like, for example, a patient 52 years old. By the time she reaches you, by the time she's coming in your office, picture that she has already seen 3 doctors, at least. One told her she was just stressed and gave her antidepressants so often. Another told her never to take hormones because they cause cancer. A third told her this is simply menopause and she will get through it like everyone else. But this patient is exhausted. She's not sleeping. Her concentration is failing. Her memory is slipping. She's beginning to fear that something more serious is happening to her. And she has already been failed 3 times by people, doctors wearing the same white coat that you and I wear. So that is why this webinar matters. The question is not whether menopause exists. The question is whether we as physicians are prepared to think clearly enough, safely enough, and responsibly enough to help these women properly. And that is why this webinar is about. It's about a concept. And for the next hour, I do not want to simply give you facts to memorize, because that would be, like I said, days. There's a lot of information in this field. I just wanted to shift the way you think about HRT. So briefly, who I am, for those of you who do not know me, I will place myself in the context. Like I said, I'm a senior MD in OBGYN, EU and Swiss board certified with a PhD from Munich, Germany, and my advanced trainings include aesthetic gynecology, advanced hormone therapies, cognitive optimization, and longevity medicine. And I'm also the founder of Hera Medical Institute in Bucharest. I run a parallel practice in Zurich. And in Romania, I also serve as the head of committee for hormone treatments within the Romanian Society of Aesthetic Gynecology. But more important than titles, I think, is this. I teach this subject because in daily clinical practice, I keep seeing the same gap. Not a gap in patient need, but a gap in physician training, in clinical structure, and in safety thinking. And too many women are denied HRT out of fear. Too many. Too many are treated without enough precision. And too many doctors are left to improvise their way through one of the most important long-term interventions in women's health. And this is why I built this framework. And what I want to go through with you tonight, it's first I want to define the current reality briefly of HRT, why it is still underused, feared, or applied dangerously. Then I will show you the shift from a traditional symptom-based model to a modern precision-based model. This is maybe the most important shift in the modern medicine. It applies not only to HRT, it applies to the entire medical models or healthcare model. And after that, we will look at what a more complete and clinically responsible HRT framework looks like. A couple of modern protocols for beginners, one that integrates safety monitoring, individualization, and long-term thinking. You will see them listed. And finally, I will show you why this topic cannot be reduced to only hot flashes, mood, or cycle control. It's about neuroendocrine aging, as a matter of fact. And also protection, cardiometabolic protection, cognitive protection, and the next 30 to 40 years, or maybe more, of a woman's life. So this webinar is really about one thing, moving from intuition to structure. So why this webinar? Because the problem is not only that HRT is controversial, the problem is that it is too often approached without coherent clinical framework. You might have for sure encountered all these aspects yourself or from colleagues you are working with or from where your patients are coming from. Some physicians still avoid HRT almost entirely. Others prescribe it too casually. Many are caught in between, aware that patients are suffering, aware that hormones matter, but not fully confident in the clinical reasoning and in the safety to prescribe them HRT. And that uncertainty is very costly. And you will see, I have prepared several slides for you to make you aware of what you are losing by not being in knowledge of safe HRT. It costs, first of all, your patients. It costs women years of unnecessary suffering, sleep, mood stability, cognitive performance, bone protection, metabolic flexibility, sexual health, professional functioning, overall quality of life. And it costs doctors confidence. So tonight, my goal is not to make HRT look easier than it is, because it is not. My goal is to make it clearer, more structured, and safer. So I have just placed here a slide just to look at the different endocrine aging states of a woman. And I want to just briefly broaden the frame, because when we speak about HRT, we are not speaking only about one patient category. We are speaking about perimenopause or menopause, or even premature menopause, or even primary ovarian insufficiency. So these are, first of all, not identical situations, but they do have one core issue: loss of ovarian hormonal support. And second, they extend on a very large time frame in a woman's life. Okay, so I want you to move away from the idea that HRT is a narrow gynecological topic just for women in menopause. I don't know, first 5 years of menopause. It is not. It is an endocrine, neurocognitive, metabolic, cardiovascular, skeletal, and quality of life topic, which is really extending or can be extended for a long time in a woman's life. So I would like you to look at the traditional model and at the aligned health model of the modern medicine. This is quite a parenthesis, but I like to use this slide in my presentations because it is so suggestive. What we would like to do is personalized medicine. We would like to align with this personalized health model where we prevent and where we have performance in our treatment protocols because we personalize them. We would like not to be in that stage of a patient where we treat symptoms. We would not like symptoms to occur. We would like really to make prevention medicine. And we would like to do that through lifestyle changes, cellular healing, detoxification, and so on. So not drugs and surgery, but supplements and lifestyle measures. So what we aim also through HRT is customized, personalized treatment protocols. And these are through proactive and holistic management of our patient. It's not a reactive medicine, what we would like to pursue. Reactive meaning when patient has symptoms, comes into the clinic, gets a diagnosis of her disease, and then starts to take medication or surgery. This is already too late. And with HRT, this is one of the fields where we can really do prevention. But it is very important that our patients are proactive. And last but not least, it is our duty to inform them and to keep them proactive. Okay. And on the long term, this type of healthcare is affordable and saves money on the long term, as opposed to medicine, surgery, and aftercares, and so on. So this leads naturally into the term of global crisis of HRT, because once we understand that, it becomes much easier to see why the current situation around HRT is not just confusing. It is really clinically unacceptable, in my opinion. I don't know how it is in your country. Maybe you can write some words of how HRT is seen in your country. But as concerning me, I can see almost the same patterns in Romania as well as in Switzerland. So this is why I think the concept I've created and the frameworks I have created are really very strong base for you to start growing in this field. And basically, it's not about learning HRT in this webinar. And I'm not here to tell you what to prescribe, because as I told you, this is information which takes a lot of time. But to show you how to think clinically about HRT. Like I said, the traditional model is incurring symptoms, disease, and death. It's very simple. While the aligned model, where we would like our patient to be, is not even in the normal range, but in the optimal range. Okay? So what we would like through HRT and other health protocols we are doing for our patients is to keep our patient, or to bring our patient and then maintain our patient in the optimal range, which is far away from symptoms, as you can see. Okay? So what I see in the clinic almost every day is dangerous HRT, I call it. There are a lot of situations, and I will briefly list them, because you might encounter them as well. And these are cases which I see almost on a daily basis. For example, patients who come from their gynecologist because they did not recommend HRT. Or gynecologists, okay? So keep in mind, or patients who come from their family doctor who told them not to take HRT under any circumstances because they will get cancer. And here I have written a big caveat, because once a patient is told that HRT is dangerous, or that it could lead to cancer, cause cancer, it is so difficult to convince the patient the other way around. It is the most, in my opinion, the most difficult situation. Once she was told unjustifiable that she could get cancer from HRT, it is so difficult to approach this patient and to give her HRT. Anyways, then we do have patients who have HRT from other doctors, but do not feel well. And this is because details are missed. Details about dosages or monitoring the existing dosage, details regarding administration recommendations. And here I am talking specifically about instructions on how to administer the specific products you have chosen for your patient. Explain her when to take it, time of the day when to take it, how to apply it, exactly where to apply it on her body, because she doesn't know. So details that matter a lot. Collection recommendations, yes. So serum testing is so important. What days to choose, what time frame to choose in between applications, very important. Or even monitoring. They receive a prescription and then they go away from the office. They are not told if to come back, when to come back, what feedback they should expect, and so on. I have put together really the most important medical negligences, I would say, in terms of prescribing. Maybe the patient has a correct prescription, but due to lack of details, she is really not having the benefits of the therapy that has been prescribed, because the doctor couldn't give her, or missed to give her, important details. So this is one of the reasons why HRT consultations need time. You cannot do an HRT consultation in 15 minutes or 20 minutes. You need, like for an HRT consultation, probably 1 hour in order to be specific, to give the patient all these details and so many more. Then, for example, I see patients with transdermal progesterone with intact uterus, while nowadays we know studies show that transdermal progesterone is not considered safe for endometrial protection. Still, you can meet such cases as well. Then I see patients with certain comorbidities, being it diabetes or arterial hypertension or other comorbidities, who have been refused HRT because they do have comorbidities, which is so wrong because the majority of comorbidities can benefit from HRT. Of course, the parallel treatment of the comorbidity is very important through a specialist, through another specialist. But in terms of, for example, diabetes, estrogens in HRT can improve the glycemic control and can lower the dose of anti-diabetic medication the patient is taking. Just one example. And then we do deal also with patients who are reserved about HRT. So these are patients whom we need to take a lot of time to explain them benefits, risks, shared decision mechanism, principle, and so on. And these are patients who need a lot of time and maybe several consultations until they decide on starting on HRT. So bottom line, unsafe HRT is dangerous. And precision HRT provides protection, very important. So what is the shift? The shift is to think of hormones not as punctual therapy, as a momentum therapy for your patient, but as neuroendocrine drugs for longevity. Because they are part of any longevity protocol. They are the nucleus of any longevity protocol. Nevertheless, there are other major segments of any longevity protocol, but hormone is a part of it, and very important part. In terms of benefits of HRT, I would just like to point out 3 major comorbidities, pathologies that can arise in menopause without a hormone optimization. The big 3 aging risks for women without HRT, for women in menopause. It's a cardiovascular disease, number 1, cancer, and cognitive decline. And we now know through several studies that HRT protects women against these major diseases. And it is not that they protect the women, but they are very important if they are initiated, the therapy is initiated in a certain time frame, not very late, not 10 years after entering menopause, but very soon, or in perimenopause, or very soon after entering menopause. Then the protective effect is proven and the benefits are there. So overall, HRT has protective effect on the blood vessels and the heart. It has anti-cancer effect generally, and also it protects against cognitive decline. So if you are new to HRT, or you are not prescribing for a long time, what I would suggest is starting simple, just estrogens, progesterone, and maybe testosterone. Start simple, master these 3 hormones well in different treatment schemes, different administration routes, and so on, and then go further. So this would be a very good start for someone who did not do HRT until now or who wants to start with HRT. And because estrogens, progesterone, and testosterone, the main three hormones produced by the ovaries, so we need to master these because these are declining in the first years of menopause. And by estrogens, I mean all three estrogens: estradiol, which is the most potent estrogen, estrone, which is predominant in menopause, and estriol, which is the weakest estrogen. And the roles of estrogens, I have listed here just a few. You can read them through, but nevertheless, you might be aware that estrogens do have receptors on every cell in a woman's body, and not only on the cell membrane, but also in the cell, on the cell nucleus. So you have different types of estrogen receptors. I'm not going into details now, but due to the fact that every cell in the woman's body does have estrogen receptors, you can imagine how important estrogen is for a woman's metabolic economy. Not to mention bone density, metabolic rate, insulin sensitivity, body temperature, muscle mass, mood, concentration, cardiovascular, blood vessels, collagen in the skin, blood pressure, cognitive, memory, motor skills, detoxification, lipid profile, etc. I have listed here just a few. And when a woman has estrogen deficiency, also I have listed just a few of the symptoms. And you might recognize a lot of symptoms which are present in your patients when they come to you. And this is how a woman briefly is looking when estrogen deficient, and how she is evolving from a young estrogen-rich woman to the later years, the older years, when estrogen is deficient. And estrogen deficiency is manifesting in all areas of her life: sexual area, emotional, cognitive, skin, brain fog, poor concentration, memory problems, depression, fatigue, all her physical aspect, yes, small, saggy breasts, laxity of her skin, joint pain, not to mention the night sweats and the hot flashes, which are maybe the most present ones, vaginal dryness, and so on. Then we do have the second main hormone, which is very important to master when you start doing HRT, which is progesterone, which is also produced by the corpus luteum, the principal source after ovulation. And it's also present as a small production in the adrenal glands. And the roles of progesterone are maybe underestimated. Oh, progesterone is just for endometrial protection and can help with sleep as well. But look, there are a lot of progesterone receptors also at the central nervous system, at this level, pituitary gland, also in the breasts, also liver, kidneys, bones. Very important role of progesterone, like an anti-inflammatory role, and very important in the immune system. And also it reduces blood pressure, also very important in cardiovascular system. Also has a diuretic effect, and like I said, it improves sleep, which is a well-known benefit of progesterone beside endometrial protection when given along with estrogens. And look how a woman is how she's looking when she's progesterone deficient, because then we do have a relative or absolute estrogen dominance. So she is going to gain weight when progesterone deficient, especially around the hip or the waist. She's going to have, depending on the life stage she is, maybe PMS, or there can be overlapping symptoms. For example, night sweats or hot flashes can be also due to progesterone deficiency, not only to estrogen deficiency. So there is a certain overlap of symptoms, mood swings as well, depression, emotional lability, overlapped symptoms with estrogen deficiency. But anyways, it is a very important it is a very important hormone to balance along with estrogens when we consider hormone optimization or hormone replacement. And then, as I said, the third main hormone which you should take into account optimizing in your patient when starting on HRT is maybe testosterone, which is also produced as a principal source in the ovaries and secondary also in the adrenal glands. So testosterone has like a couple of important roles. It is known for its role in the sexual function. But nevertheless, I must tell you that when administering testosterone in women in menopause, for example, in an HRT regimen, for example, the doses are quite low. They will not dramatically improve sexual function in a woman at those doses. So this is why when I am explaining patients the roles of testosterone, I'm putting sexual function at the bottom. The last benefit I will tell her is sexual function. But there are a lot of other very important roles of testosterone: maintaining the bone density, maintaining the muscle mass, protecting the brain. Like this brain fog many patients are coming with are due to lack of testosterone, you know. And upon administering testosterone, they really come to life again and can think again and can look to you again precisely, because otherwise they're looking through you. They have brain fog. So mental health, brain fog, concentration, attention, focus, drive, energy throughout the day is very important with testosterone. And you don't need high doses for that. Symptoms of testosterone deficiency do quite overlap on the symptoms of estrogen deficiency. I will not enter into details here. I have just listed the most frequent symptoms of testosterone deficiency, like apathy, low libido, low sexual response, dyspareunia, low energy, depression, brain fog. These are the main symptoms you can spot in a patient with testosterone deficiency. But nevertheless, when you administer testosterone, you should stick to the serum values and administer accordingly. So what we see is this is not menopause. This is endocrine aging. It is obvious, right? It's endocrine aging. So our responsibility is not, it is of course controlling symptoms, but it is not only controlling symptoms. It is to protect the next 30, 40 years, maybe more, of our patient's life. Okay. And precision in what you are administering changes everything. And it changes everything not in your patient's life, but also in the fact that she's going to come back to you, because she's going to feel good. And then you will have a patient for life and many more patients for life. So this is really, I say always, this is a niche you can enter without doing anything else. If you're an OBGYN, let the pregnancies, let the births, you can do only this. And this is already very rewarding. And if you do it well, you will have a lot of patients coming to you and sticking to you. Yeah. So what needs to be taken into account in administering HRT is a complete management. So the framework would start with information, support in decision making, yes, regarding the management, holistic and individualized approach. You do always a personalized treatment protocol for your patient, not a universal one, because it would not fit to her, then she will not feel good. You need to think, what is she needing, this particular woman? Along with lifestyle recommendations. These are as important as HRT. So you're doing your job in prescribing her the HRT correctly and the correctly supplements, specific supplements, and she needs to understand that she needs to do her job as well in with regards to lifestyle. And here by lifestyle, I mean physical exercise, a correct diet, and good sleep hygiene, stress management as good as possible. So these are 4 homeworks for your patient, which she needs really to understand upfront. Yeah, you cannot do magic if she's going to bed at 2 a.m. or if she's drinking a lot of alcohol or eating a lot of sweets, or she's not doing exercise as well. You cannot do magic. And this is what you need to explain her from the beginning, so that she's not being frustrated or disappointed after that. Then we need to take into account the comorbidities, counseling on risk factors for existing or potential comorbidities. Then, after everything has been done, choose the right treatment options for your patient, counsel her regarding risk and benefits of the specific HRT you have chosen for her. Yes. Given the fact that in the last guidelines, which are from NAMS, the North American Menopause Society, last statement, last consensus was issued 2022. They state exactly that phrase, that HRT is considered the most effective treatment for menopausal symptoms for most women, meaning for healthy women. So this is something you need also to emphasize to your patient. Of course, we need to do risk assessment. I will not go into details here, but it is very important, yes, to know what type of hormones you are administering to your patient. Is it body identical, bioidentical, synthetic? What type of progesterone? What type of route of administration? Is it oral? Is it transdermal? And so on. So risk assessment may be also in terms of the HRT, which is applying to your patient, but also in terms of her particular risk factors. Okay. So, like I said, you need to start very simple. If you are a beginner, if you did not do any HRT before, or you have just started and don't know exactly how to manage that, you need to stick to these 4 steps. Admission, meaning the patient has to fill out a questionnaire, a very basic questionnaire regarding her symptoms, regarding her medical history, regarding her present diseases maybe, and so on. Then you, based on these information and other questions you are placing to your patient, do a risk assessment for this patient. Very important. Keep in mind here also the family history of your patient. For example, if her mother has breast cancer, then you will do a risk assessment for breast cancer right away for your patient and tell her what what risk she has, or other risks. Then, after having all this information, having done the risk assessment, and of course all consultations, necessary consultations, including complete pelvic exam, complete breast health screening, and other consultations if necessary, you will issue a personalized HRT plan, plus some supplements which you consider important for your patient to complete and to maximize the efficiency of your HRT plan. And then you will monitor it. So admission, risk assessment, personalized HRT plan, and monitoring, very important. So it's not HRT is not a prescription. She's not coming in your office, like after 20 minutes, she's going out with a prescription, take that. No, it's a path of clinical reasoning, which is very important in order to have results and for your patient to have benefits and to stay healthy and risk-free. So this is how safe HRT looks like. I would like to present you just briefly 2 clinical cases. Just like an example, like the first example I have given you at the beginning of the webinar, very common in the practice. For example, one case in perimenopause with insomnia and anxiety, so typical. Yeah. She comes with age 47 with insomnia, anxiety, palpitations, and weight gain. And she was told she's stressed and she was prescribed already an antidepressants. So she's coming to me because she's a patient of mine. She came to me already with an antidepressant treatment. Also, a very difficult situation, yeah, because you cannot argue, contradict a colleague in front of your patient. You definitely do not agree with what she has, so you have to be very diplomatic about how to switch her briefly and slowly and very risk-free to something which she needs. Because if you're doing her labs, I did her labs in this patient. So she had fluctuating estradiol, a very low progesterone already under 0.5. Yeah. So she does not need antidepressants. In my opinion, she didn't need antidepressants. She needs neuroendocrine stabilization. So I put her on a low dose transdermal estradiol and progesterone in the evening, monitored. In a couple of weeks, she had another life. Her life really changed. She could sleep. Her anxiety was much better. She could leave off the antidepressants. So it's very important to spot which person does really need medication and which person does need a neuroendocrine optimization. Another case, also a patient of mine who impressed me in postmenopause. She came to me already age 58 with hot flashes, low energy, brain fog, memory loss, and fear of Alzheimer's disease. As a matter of fact, her daughter brought her to me because she noticed some cognitive decline in her mother, like when she was talking to her on the phone, she could not remember things from previous day. And so she brought her mother to me. She was in menopause since age 51, did not take any HRT. And listen to that. She already had, also, she was just slightly overweight. I would say slightly overweight. So not even frankly overweight. She already had diabetes type 2 and arterial hypertension, high blood pressure already. And she didn't have these until she entered menopause. So all these diseases she got when upon entering in menopause. So she was told, why was she not on HRT? Because she was told HRT is dangerous. So then she didn't seek out a second opinion. She was just resigned with this opinion that HRT is dangerous, that she needs to suffer. And currently, of course, she was taking treatment for her comorbidities. She was taking treatment for diabetes, treatment for high blood pressure. In the lab, of course, as expected, subminimal values of all hormones, estradiol, progesterone, testosterone. Of course, we could not have expected anything else. So what was her concept for treatment in this case? Of course, we cannot do prevention anymore. So this is what I told you at the beginning of the webinar regarding a window of opportunity for initiation of HRT. In this patient, the changes have already been installed, have already created damage. So what we can do now is just stabilizing in this stage, stabilizing her changes. Neuroprotection, cardiometabolic optimization, of course, regarding cognitive decline, because now I know a lot more after having done my certification in cognitive optimization. I know a lot more than I knew before, and I know exactly what are the tiers to be investigated and possible to be treated in a neurocognitive decline. And now I know that even incipient early Alzheimer's disease or subjective cognitive impairment, like it was in this patient, not even early Alzheimer's disease, so she was on an SCI now, can be reversed when you investigate these tiers and when you give the proper treatment. But of course, there is a lot of discipline required on behalf of the patient. And this is why, in particular, these patients with a slight cognitive decline maybe need also a health coach beside, so they stay focused on their treatment. But this is just as a parenthesis in this particular patient, because all changes have already been installed. We cannot do prevention anymore. So we aim to start HRT. It is useful to start HRT even in this patient because we can stabilize her. Yeah. So it's very important also. So you cannot say, oh, I'm sorry, now it's too late. No, it's not too late. You can still stabilize. You should choose the correct doses, of course, so that she's not at risk. Small doses. I gave her estradiol, transdermal, progesterone in the evening. So very simple. You see, not even testosterone, not in the other patient, not in this one. 2 hormones. If you master these, you can do magic for your patient. So in this case, the aim was to start protecting her brain. Not the hot flashes, they were important as well because her quality of life changed a lot. And she was much more motivated to start physical exercise. I have explained her exactly how to start, because in a woman age 58 who did not sport in her life, she, as a matter of fact, is a librarian as a profession. So she sat at the desk the whole day. It's just, you cannot tell her simply like, go and do gym, go and do sports, and go and do some weight training or so on. It's impossible. You need to just start with very small steps and tell her precisely how to start and what to start with. This is another story. Anyways, she changed completely when she came to me even 1 month after she started on treatment. She was somebody else. She said, I am now able not to eat so many sweets anymore. I am able to not eat between meals anymore. I started on exercise. I have more energy. I'm not drop dead in the afternoon. So she was some kind of another person. And we are continuing with the treatment. Okay. But safety first. So in order to be very safe in the HRT you are prescribing, you need to know the theory. You need to know everything about HRT in detail. Contraindications, list absolute relative contraindications. You need to dream them. Risk assessment, how to do that. What are the major risks in HRT and how are you evaluating them? Which of these situations are neutral to HRT, so are not influenced, which are at contraindicated, and which one are to be avoided or to be administered with caution. So very, very well knowledge. You need to have a good knowledge about it in order to be confident in what you are communicating to your patient and what you are prescribing eventually. Adverse reactions, you need to know them. You will learn them out of experience. But on the other hand, you need to know the theory because, of course, patients know much less than you know, and they can go home with their prescription. They can start on HRT, and then 2 days after, they call you. I am bloated. I have water retention. I have headache. I'm bleeding. I have breast tenderness, and you should not panic. You should know what to tell them. Yeah. Then monitoring is very important, when to call them back, what to check at each monitor session, follow-up session. Shared decision-making is also very important because not always your opinions or your recommendations are superposed by the patient's ideas, opinions, preferences. So you need to really get along and come midway with your patient and take a shared decision. And this is also a very important tool of yours. And also, don't forget to document everything very good. So everything should be documented in written. Consents, questionnaires, medical report, and so on. And inform the patient. Information, this is why I told you it's a lot of time you need for a consultation. So hormone replacement, once again, is not a bold prescription. It is a safe prescription. when you do it correctly, and this is how we protect our patients and ourselves, of course. And of course, I think this is or was or is a deficiency in the medical education. We were not taught to do that. Not in university, not in medical school, not after that, not even in our specialty residency or specialty formation as specialty physicians. So the gap isn't in you, it is in what you were taught. So most physicians, like I said, prescribe, maybe they prescribe HRT, but intuitively. Yeah. It's not because they don't care, it's because no one ever told them the framework, the system, the algorithm, which they should respect. No standardized algorithm, no clear safety framework, like, for example, risk evaluation, and no longevity vision. So if you see a patient and start her on HRT, you should see her like your lifetime patient. This is it. So, because this is not a short-term therapy. This is a lifelong therapy, okay? And of course, it needs adjustments. It's not, so this is, you should not see it personal that you cannot prescribe HRT. It's not your fault. It's really a training gap, yeah? So, as you have seen, this very important that you master an algorithm and start from here. I showed you only a slide with the algorithm, but these are several chapters, yes, to be learned, to be gone through when you want really to be very precise in what you are prescribing, okay? Okay, so now I invite you, if you think this framework, this algorithm, this whole concept of HRT with a broader focus on longevity for your patient, for your female patient, is something you deal in your practice with, or you might want to learn, I invite you to move forward or further from clinical intuition, which you might have, to the medical structure. Yeah, because finally, this is not a HRT, not a simple therapy. As you have might seen, it's a clinical discipline. You need to take into consideration so many factors. Even if you're an OBGYN, you need to know how to assess her risks, how to assess her lipid profile, how to assess her HOMA index, and so on. So it's a lot of other stuff you need to know in order to be precise, okay? So this is why I have built courses for HRT. I have built a course about clinical thinking in HRT. And this is going from the basics, from fundamentals to precision, personalization, and longevity integration. And I have built a course for beginners, separate. Until this year, I have done one course, only one course. So I'm doing HRT courses for about 5 years now, for doctors, for physicians, to train them on how to prescribe HRT. And this is the first year where I have split, because I have seen basically physicians who already started to prescribe HRT and needed more detailed information, more refinement. And there are a lot of young physicians who would like to start on prescribing HRT, or they're not experienced and they would like to start. So I said, now this needs to be split. And it was really worth, because the information got even more valuable. In the course for beginners, they are 12 hours all in total, where we discuss about the foundations of the female hormones. And I have also listed here the modules we are talking about in this course: protocols, monitoring, also with focus on longevity, in brief focus on longevity integration. But basically, we assess the theory, female hormones, evidences, myths, and safety with regards to HRT, so that you can counteract in the discussions with your patients, because patients are very informed nowadays. So they come with clinical studies, they come with ChatGPT, they come with a lot of information, and they said, okay, doctor, now explain me. How am I not going to have breast cancer from HRT? So you need to know how to, because this study and this study and this study, yeah, you know, to know, you need to know how to discuss these matters with her. Assessment protocol before starting HRT, basics of estrogen therapy, of progesterone therapy, and of testosterone therapy in women, monitoring, follow-up, and adjustments, very important, and then longevity integration and clinical cases. This is the beginner's course. And then we do have the advanced course, which comprise more complex information and also more complex clinical cases. We are, of course, starting with evidence-based current guidelines. Very important for you to have them as a staple in the communication to your patient. Refined diagnosis of different life stages in which HRT is necessary, indications and patient selections, contraindications, risk assessment, forms and administration routes, and then we go into bioidentical hormones and even non-hormonal alternatives for those patients who do not uh, who do not who cannot take HRT, yes, who have no indication or have a contraindication for HRT, or even who do not want to take HRT and have several symptoms. We discuss special populations, so special risk or comorbidities populations in a quite detailed module. Long-term management, discontinuation of therapy, what happens and how it happens when a patient wants to interrupt HRT. Also, brief perspective on emerging therapies and future directions, very interesting. And I have built in a module especially for shared decision-making and communication to patient. How is this working? How are you telling her some phrases, exactly phrases that you can tell to your patient in order to be safe, in order to not panic her, and so on, and what are the steps to reach a shared decision with your patient. And then also we do have a workshop of complex clinical cases. Each of these courses does have a quiz at the end of each module, so that it's basically a recap quiz in which you can consolidate the information from each module, and at the end you would have a certification test, a longer test, for applying all the knowledge learned in the course. And it is, of course, a test which you need to pass with a certain percentage in order to get the certification. But nevertheless, you would have access to the course for several weeks, so you can recall some modules which you consider are weaker, and review all information. And what I consider very important at the end of each course is that I am challenging you in a brief evaluation questionnaire, to write exactly down, following this course, what are you going to implement in your practice starting tomorrow. This is very challenging. So basically, you can get the beginner's course or the advanced course, or you can get both courses, plus what turns a course into a discipline. And here I mean not only the recorded courses, but you get an international certification, an international accreditation certificate. You get the full clinical toolkit. Every course comes with handouts comprising materials which you can use in your practice starting tomorrow. So built-in templates or tables with hormone doses, which you can already use. So then you also do have incorporated, when you choose to take both courses, beginners and advanced, you may benefit from 5 live mentorship sessions, which are basically Q&A sessions. I would organize live in order to discuss cases you have, maybe starting prescribing HRT and not sure about things, or you have more complex cases which we can discuss. And then last but not least, you enter a community of physicians where you can exchange information, get up to date with all news, and share your cases, of course, or your experience. Okay. So this is just to, again, make you aware of the fact that these courses don't learn you what to prescribe, although they do learn you what to prescribe, because we have a lot of cases which basically cover all possible scenarios in your practice regarding HRT. Hormone HRT and also the non-hormonal alternatives in some patients. We learn how to think. Yeah, so this is the advantage of the courses, that you really cover the entire spectrum of HRT from the patient entering in your office until she dies, until she gets 100, 120. Yeah, how to manage her. Okay, so it is really a medical course, really only medical information applicable. The second day after you finish the course, you can apply the information. It is correlating all current evidence-based guidelines up to date, so that you are able to learn everything in safety. It integrates also the longevity principle in terms of other aspects which comprise the longevity of your patient. Just a couple of testimonials from physicians who took this course. If you would like to read them, this is interesting. They are spontaneous testimonials, which we are happy about. What are the prices of the courses? I would just let you go through them. What you are actually getting, the complete package would be today, because we do have special webinars offers. So the package would be 1,797 euros, the complete package, if you buy it 48 hours after the webinar at latest. So today, or another 48 hours after the webinar. But if you would add up everything what you get in the package, then the structure would look like this, like around 3,500 euros, because it would comprise separately the beginners and the advanced course if you would purchase them separately. Then it would comprise the international CME accreditation. It would comprise separately, if you want to book them, the 5 live mentorship sessions, Q&A sessions. It would imply private physician community, which is a special membership rate, and the full clinical toolkit and templates, handouts would also have a price. So all in total, you would have a much higher price than having this package. But again, to remind you that this price is just a webinar price. So it's just for today, and 48 hours after the webinar is ending, is this price available. If you choose to take the individual course, then we do also have a preferential rate for the webinar. If you would like to take only the beginner's course or only the advanced course, it would be 897 euros today and 48 hours after the webinar. But of course, the package would be, in my opinion, worth, because sooner or later you would get experienced and you would like to take the advanced course as well. Here is a very interesting comparison, which really is true, because the real math shows you that the course is paying for itself with only one patient. If you manage, and here I have put really the basic prices for a patient, because it could be much more. You charge a patient for HRT during his consultations and follow-up consultations. So let's say an average amount which you charge per patient for an HRT patient per year would be around 2,400 euros. So it's really this package, if you purchase it, would really pay with one patient. But like I said, if you would start to master the HRT, you would be really so overloaded. It would be difficult for you to manage all patients in real time. You would have really waiting list. Okay. Then regarding the complete package members, so those of you who choose to purchase the package, the beginners and the advanced course in a package, would be part of this member community for the live sessions, the Q&A sessions. We include a small group in each Q&A session, maximum 20 physicians, because we would like to discuss real cases, your cases. It's not me talking there, just interacting with you regarding the cases, maybe share opinion and counsel you regarding next steps. So this is basically the advantage of being in this community when you choose the package, because you then do have 5 live sessions, Q&A sessions included. Okay, so I always say this is for you if you want to practice HRT. If you don't want to practice HRT, then it, of course, doesn't make sense. If you think, no, I want to do just births, I want to do just endometriosis, just laparoscopy, I don't know, then it's probably not useful. But if you want to practice HRT, this is what you need. And if you have already a practice and see that you have patients coming in for symptoms with menopause and seek consultations and seek help, especially if you see they're coming from other colleagues who could not manage them, then really this is for you, because you may become an authority in your niche, in your country, in your city, in your clinic. These are some testimonials from my website. Actually, if you go to my website, you can see them. It's just, there are a lot. I just put some here because I just want to show you how rewardful the patients are, how grateful they are. And not only this, how their life changed in such a short way after starting HRT. This is amazing. Okay, so like I said, bottom line, it's not about hormones, it's about protecting the next 30 to 40 years, maybe more, or hopefully more, of your patient's life. Okay, so again, if you would like to purchase the courses, you might purchase them individually or as a package. If you purchase them as a package, then you do have other benefits as well, like, for example, the Q&A sessions, live sessions, 5 Q&A sessions with me and other colleagues in the community. But remember that these rates are special rates for the first for today and the first 48 hours after the webinar is ending. So you would receive in the Zoom chat the link to register. Then I'll be practical, or you may register via the WhatsApp group. There will be the link, the registration link there as well. So here I will end with two very dear diagrams for me. The left side diagram is the lifestyle diagram, yeah, and you see everything relies on the sleep, and the exercise and the diet, the fasting first and the diet second. And then you can achieve metabolic flexibility and metabolic health. This is a picture I'm showing to my patients. And then we do have the actual brain food pyramid, which is starting also with a basement on fasting. And then you can see the different categories of foods that are important or that are indulgent, that you cannot consume in high amounts. And this is only a snapshot of what we are talking in the course with regards to longevity integration, for example. So thank you very much for listening. Thank you.
Thank you, Dr. Raluca.
Hi, Diana.
Hi, hello, how are you? So, congratulations. People, first of all, I want to say two things. So, we will have now the questions that you wrote. Please, meanwhile, Dr. Raluca, I send the questions on your WhatsApp to have it more organized there, because there were some questions during the discussion. You might lose them. So, please check your WhatsApp. I send it there for you.
Second,
And
I stopped sharing, right? You can see me now.
yes.
Okay.
So please check your WhatsApp. I send it there to not to forget any questions from our colleagues.
Okay,
And just to, I want to clarify some things for the doctors, because we've had many doctors asking for this kind of courses. We organized the live courses as well, and many doctors could not participate. So we wanted to tell you, and during this meeting as well, about the possibility to have online training, because they ask, some doctors ask, when is this and where is this? It's online, okay? And we have a course platform where you'll have username and password, so you can watch the course whenever you have time. For example, we have 12 hours for the beginners. If you watch every evening after your clinic 1 hour, then in 12 days, in 2 weeks, you will finish the course. Or if you want to watch more hours during the day, it's okay. And then 12 hours for the advanced course. We will have about a lot of discussions and clinical cases. They're about cancer survivors, because it's very important. And sometimes we have other WhatsApp groups, and you know that we discuss there about what to do with cancer in a breast cancer patient, or what to do in an endometrial cancer patient or a vaginal cancer patient. And it depends about some aspects, and most of the time it's safe to give hormones, but you need to take into consideration some aspects that we discussed. Premature ovarian failure as well. We have so many patients in 40 years old that are in menopause, so we need to address that as well. Patients with endometriosis, right? So many patients with endometriosis, what we do with them? It's contraindicated, or it's good to give hormones for endometriosic patients, and so on. So you will have the link and everything on the group for the doctors that are interested in that. Now we are going to take the questions and the clinical cases. Did you find my messages, Raluca?
No, I couldn't, but I'm looking on the
It's on
chat.
your, okay. In Q&A, please. I send on your
In Q&A, okay, I
Yes.
cannot see anything in Q&A.
Yes, please look on your WhatsApp in your personal number. From
Okay.
personal number from my
Okay.
phone.
Okay.
Personal number from my phone. I put it there. Yeah.
Okay, so now we have, I think, a couple of minutes left for questions. Okay. So, how helpful is strength training in menopause? Of course, I will probably try to answer briefly all questions, but probably will not manage to do that in a quarter an hour, or how much do we have left? Like, how helpful is strength training in menopause? It is really very helpful. You need to recommend it meaningful and know what to recommend, but it's one of the specific exercise or physical therapy needed in prevention of osteoporosis, or reversing in early osteoporosis. So it's very important. Yes, lifestyle, some of them don't do the gym. Is the term bioidentical still used or compounded hormones now used? We do use bioidentical and compound, and they are separate terms. We will discuss that in detail in the course, in the beginner's course, as well as in the advanced course. We will have a module on bioidentical hormones. But to answer briefly your questions, bioidentical hormones is a term still used, and compounded hormones is also a term still used, and they are different categories of hormones. Then what are the starting doses of testosterone? This is something we will discuss in the course, because it comprises explanation along with clinical studies which are done, and along with other parameters. So I would prefer not to post a single dose here, a starting
it's
dose,
personalized.
because it's a
Depending on the age,
discussion.
on the history,
Right,
on
right.
the symptoms, on everything. It's not a starting dose for everyone. It's not the same.
How does testosterone deficiency cause hirsutism? So hirsutism is basically a side effect of DHT, of dihydrotestosterone, which is actually a metabolite of testosterone. And speaking of that, we didn't mention actually the course we are also organizing, or have also recorded. I have held it like 2 days last week, about estrogen metabolites and sex hormone metabolites, the Dutch test, which we are also having on our platform. Very interesting in relation to this question you have posed, because testosterone is only a downstream metabolite of DHEA, for example, or of pregnenolone, but downstream it moves to certain metabolites like DHT, dihydrotestosterone, which can cause hirsutism, which is actually the intracellular activity proof of testosterone. So yes, it can be so. This is another course. This is not something you will learn in the classic HRT course. This is mainly addressed in the Dutch interpretation course.
Yeah, and this is important because sometimes, like, you see the hormones in the blood, and it's different that the metabolite you see in the urine. So sometimes you have patients with symptoms, and you look at their blood test and you see, oh, the hormones are good, and why does she still has these symptoms? And you give her maybe hormone replacement therapy, and still she has symptoms, and you don't understand why this is not working. And when you know how to interpret not only the blood, the hormones in the blood, but as well like how they are metabolizing in the body, and then how they are now in the urine, you can understand how their path is from absorption, secretion, and metabolization. So maybe the pathway of the metabolization is modified, so you don't have to give more hormones, for example, but you need to improve the methylation, the metabolization, the other things. So this is why the Dutch test is a very important tool. Our course is 10 hours. You can watch 1 hour per day, or how you want to do it, and it's very interesting because this will make you really special. Like, not a lot of gynecologists or doctors know how to interpret this. So you will be, first of all, you will be an expert in hormones, like the beginners and advanced, and then you'll be a niche with this Dutch test. So I'm sure that in your area,
Diana, you disappeared. At least can you hear and see me? Because I would take over. Can you write in the chat if you can hear and see me?
You should take over. I think she got blocked.
Shall I take over?
Yes.
Okay.
Continue to answer to the questions.
Okay, so then we do have, ich würde gerne in Zürich arbeiten. Okay, to work in Zurich, yes, you can. There's a lot of there are a lot of opportunities, and but you need a Swiss certification, which takes time. You cannot work in Switzerland with an EU diploma certification. Okay, so Taking another question, what would be considered the optimal menopausal hormone therapy regimen for a 53-year-old postmenopausal woman with multiple sclerosis and limited mobility, whose primary goals are the prevention of osteoporosis and reduction of cardiovascular risk? This is very interesting because we do have a chapter on multiple sclerosis specifically in the advanced course. So there is a discussion here. Of course, she can take hormone therapy. It depends a lot on the stage of her multiple sclerosis, and she needs a specific consultation, specialty consultation, a medical report, and then you can decide together with the specialist if she is eligible for HRT and start her on HRT. But multiple sclerosis per se benefits from HRT. After the presentation, would like to know if dense breasts on mammogram 5 years post-menopause is a contraindication for menopausal hormone therapy. No, it is not a contraindication. You need to assess correctly, properly, the situation through, of course, the standard evaluations like ultrasound and mammogram. And if not concludent, then you might do also an MRI, breast MRI, which is maybe more specific or sensitive for breast, for dense breasts. But if everything is all right, then you can start with HRT and monitor accordingly. It's not considered dense breasts, are not considered risk for HRT. For years, the opposite was claimed, caused cancer because of HRT. Yes, for years, the opposite was claimed, cancer because of HRT. I'm dealing with these discussions in my patients a lot. And this is why in the courses, beginners as well as advanced, I have addressed this really seriously. We are discussing the WE studies in a separate module. What did the WE studies? What did they wrong? What did they learn us? And so on. So, and how they report now in terms of the modern HRT. And there's a lot we have learned from the WE studies. But now, as HRT is considered mainly with having an anti-cancer effect. It's not considered cancer risk HRT. And of course, we need to evaluate it accordingly. So, but we need to know the information ourselves, and then we need to know how to present it to our patient. Okay, administer only after blood work or lowest dose no matter what, depending on the stage of the patient. For example, in perimenopause, as we will learn also in the course, perimenopause doesn't necessarily need hormone evaluation. Even postmenopause doesn't necessarily need hormone evaluation. So depending on the life stage of our patient, we would evaluate hormones. I prefer to check hormones mainly to see that there are no extremes, not very low, like for example in perimenopause, or not very high due to certain conditions in menopause. So I like to check them, but I never adjust the doses according to the serum levels. I treat the patient, I treat the symptoms. I do not treat the value, the lab values. Okay, and this is a principle. Okay, so then patient 49 FSH 30. These are, for example, cases which we could discuss in the Q&A sessions. Basically, this is the typical Q&A session with cases. 49 FSH 38, periods every 2-3 months, has extreme fatigue even after 8 hours sleep. What specific blood tests plus symptoms score tell you it's time for HRT versus check thyroid or iron instead? You need to check all of them. Yes, you need to check hormones, all hormones, including thyroid hormones, adrenal hormones, make a good differential diagnosis. Also iron, very important. So also in these courses I have prepared, you do have a checklist of lab investigations, of mandatory and optional lab investigations to be checked before starting HRT. This is the assessment before HRT list. What is your mandatory baseline blood panel? Exactly, this is it. Because it's not, please list all. These are listed all in the course. Does transdermal HRT actually improve skin collagen loss and facial aging? So transdermal HRT per se, in terms of application, is not necessarily improving skin collagen loss in the specific area where it is placed, except for this new product, which has been released now worldwide, which is the estriol cream, face cream, which is really potent on the face, but it does have cosmetic doses, so it does not have HRT doses. But apart from that, HRT has a beneficial effect on collagen because it binds to the collagen receptors in the body. So it's not having just benefits on the place where it is applied, it has benefits on the collagen, skin collagen throughout the body. So it is beneficial in this respect. So what evidence-based alternatives help collagen, supplements, peptides, creams, all of them. So like I told you, HRT is just the nucleus of longevity treatment. You cannot do only HRT and expect miracles. You need a longevity protocol. And here I always start from inside out, hormones, why not peptides, supplements, and then also from outside in terms of what you mentioned here, creams, yes, procedures in the clinic and so on. And last but not least, but it is actually the first one, the fundament, the base is the lifestyle. So it's really a holistic approach and a global approach and a complex approach. And you need to check every segment in order to get results. Patient with mother who had breast cancer at 62, no BRCA, what is real percentage risk increase with 5 years of transdermal estradiol? You need to calculate her the risk. There are different models for risk calculation in breast cancer risk. So it's not me calculating the risk. There are specific calculators depending on how many relatives she had with cancer. There are more simple or more complex risk calculators, and then you can immediately tell the patient what her risk would be. Anyways, her risk with 5 years of transdermal estradiol, depending, you didn't mention the age of the patient, that one risk is for a patient who is under 50 and another risk is for a patient who is over 50, because until 50 the risk does not really count, and after 50 the risk starts to count after 5 years. So within 5 years I would say there is no additional risk. If I start low dose HRT for fatigue plus skin, what is your protocol for tapering off after 3 to 5 years without symptoms returning? So basically, fatigue and skin are not primary indications for HRT. So if you would want to be very correct, very strict in the sense of the guidelines, you could not start a patient on HRT for fatigue and skin. She needs to have indications which are comprised in the main primary indications for starting HRT. But anyways, if you have the consent of the patient, you have informed the patient about the primary indications and that she is not included in this, and you still want to start HRT, there's no problem, but then you need to have a special consent of the patient that regarding starting HRT. And then if you want to taper her off after 3 to 5 years without symptoms returning, this is basically not so possible. In symptoms will return sooner or later, especially skin and fatigue are general symptoms which are usually progressing with age. So if she's going to interrupt HRT, her symptoms will resume sooner or later. So then here I do have something which is not complete. It's just, can a menopausal woman still can start HRT after 4 years of being menopause? Yes, she can. I have a 42-year-old patient in menopause, 1.5 year more like POF. Can you help me, POF? Patient 2, it's a long story here. We'll go to the next case because this is not very clear. Hemostasis normal. This is continuing. Please advise on HRT regime. This is a complex case. I will probably not be able to tell you any HRT regime now. Whether first to perform endometrial biopsy. Okay, this is a case to be discussed. Maybe you can keep this case if you choose to take the courses. It's an interesting case to discuss during the Q&A because we need pen and paper, we need all documents. So it's really a very responsible answer, in my opinion. It's a complex case and needs a responsible answer. So now let's move to, hold on, we have here, okay. For how long we can give? Now the current guidelines do not impose an age limit nowadays. As per the NAMS Consensus 2022, there is no age limit imposed for HRT. So you can give her long life. I have a patient who is perimenopausal, BMI 39, and a history of an episode of transient ischemic attack. She has anxiety, insomnia. Can she give an HRT? Not upfront. You need to check her really rigorously neurological and see where she qualifies. It's very important when her episode of transient ischemic attack has been. How many months ago and how she recovered, because this is one of the main criteria in the risk evaluation and in assessing the contraindication for HRT. So I cannot tell you that you can give her upfront HRT before having a very thorough evaluation, and then she might need a second discussion, a second analysis review of her case. 39-year-old female having heavy menstrual bleeding for 1 year with 3 centimeter fibroid, recently feeling depressed and mood swings. What investigation to advise, and can we give her femostone, or what is best option for her having heavy menstrual bleeding and 3 centimeter fibroid? I would probably, in context of depression and in context of her symptoms, she looks like an estrogen dominant patient rather. And so maybe I would start her only on progesterone first, a type of progesterone first, and not a combined estrogen progesterone therapy up front. If progesterone has diuretic effect, why under progesterone treatment the patient manifests hydric retention, edema? This is either a progesterone intolerance or the progesterone is not balanced with the estrogen. Do you test testosterone level before treatment with testosterone? I have told you this even here in the webinar, always. In a particular case, when the patient has MCAS, mastocytic activation syndrome, I suppose this is HRT helping or aggravating it? In this case, the patient is 54, having HRT since 48. He did cycloprogenova and is diagnosed with MCAS for the last year. Following her observations, the flares are not influenced by the cycle. She wishes to maintain HRT. She has still cycles with at 54 with cycloprogenova. Yes, you can maintain HRT, but you should maybe switch to another product, a more bioidentical product, which she would probably tolerate better. So now let me take another question. What is the best plan for a 52-year-old woman, 4 years menopausal, with hyperlipidemia and hypertension maintenance? Can we start her on HRT at 4th year of menopause? You can start her, but definitely you should address, or cardiologist should address, a proper treatment for hypertension and her dyslipidemia if she needs medication. But you can start her on HRT, of course. What if the patient, 47 years old, BMI 28, has raised cholesterol, LDL? How to manage to reduce it? And if HRT to be recommended? Yes, HRT is beneficial for LDL reduction, first of all. But then you need to send her to a cardiologist to fix her LDL, either with statins or with lifestyle, or first with lifestyle changes or certain supplements, which are proven to lower LDL, and plus minus statins if she is not improving in 2 to 3 months. So, but definitely HRT would be beneficial for her. When you measure estradiol and progesterone, depending on the age of the patient, you can measure it during the luteal phase or anytime if she is amenorrheic, but mainly during the luteal phase if she's cycling. Would HRT be safe in MS patients? Yes, I have answered this question. Do you saw a correlation between dysphoric premenstrual syndrome in reproductive life and menopause neuropsychoendocrine symptoms? Yes, they can report. Usually if a patient has PMDD, then she's more prone to depression in menopause. That is right. As a matter of fact, we do have a course on PMS and PMDD. This is a singular course. I think this is a bonus course. Maybe Diana, you can help me. I think this is a bonus course in the beginner's course, the PMS, PMDD course. You do have a bonus course, I'm not sure. But anyways, we do have it also separate, the PMS, PMDD course by itself. Very interesting.
Yes, because it's very important. Some patients, young patients, I talk with my friends that are psychiatrists as well, and some smart psychiatrists first send the patient for a hormonal evaluation from a gynecologist before giving her antidepressants, because sometimes she has a hormonal imbalance, and this causes her depression and mood swings and everything like that. And the same in the menopause. Of course, this doesn't mean that all depression is caused by hormones, but a lot of them actually are way improved when you add optimization of the hormones. So that's why we made a special part of the course about premenstrual syndrome and premenstrual and the depression syndrome associated with the hormonal imbalance, to understand your patient, to see when her symptoms are due to the hormones and when it's due to something else. You need to tell her that. Yeah.
Okay, then what are the cutoff values for estradiol and testosterone for treatment monitoring? This is also addressed in the course in detail, because you do have chapters, separate chapters for estrogen, progesterone, testosterone, and you also have this in a handout. It's a handout you receive with the course
So
to use it.
We don't answer this question now, not because we say like, okay, you need to see it in the course, but because this is a discussion for at least 20 minutes to have it all clear. So it's important to not to say like, for all the patients, you need to do like this. Everything needs to be personalized. So for one patient, this value is normal. For another patient, this value is normal, depending on other factors. So that's why it's important to personalize the treatment and to understand the patient. This is what Dr. Raluca said, that this course is not like to understand some blood tests and to understand how to give some products, but to understand the physiology and to understand the longevity and optimization, and to help each patient in their own way. That's why you need at least 1 hour to discuss with each patient. So you need to have all this information in order to give it back to your patient. And this is important because, first of all, it's important for you as a doctor to be safe, to know all of this, and not to say like, oh, I had a webinar and they said that this value, I need to start testosterone is 0.35. So I give you this, and why someone tells me it's not correct? Because it depends on the patient. So It's safe for you to have all this information. It's like 24 hours of course, okay, and then 5 months of mentorship. At the mentorship, it's online with Dr. Raluca Hera. So after you finish the course, you'll have 5 months to have live discussions with Dr. Raluca about your clinical cases. So you'll be sure that you are doing the right thing and understand the right things, because sometimes you just finish a course and then you have the complex case in your clinic, and what I'm going to do with this patient. So it's important that you have access to Dr. Raluca and as well to our community. So yeah, it's important to be safe for you as a doctor and to the patient to be safe as well. Okay, sorry for the long introduction, but just wanted to be clear, because we need everything to be good for you and for your patients. Okay, Dr. Raluca, I can continue.
Okay, there's another case, total hysterectomy for papillary adenocarcinoma, am I right? And HRT. Yeah, normally endometrial carcinoma, if it's endometrial carcinoma, it's not a contraindication for HRT, but it's depending a lot on when it was done, what stage it has been, and so on. But usually an early stage eradicated, so treated endometrial carcinoma can benefit from HRT. With this speaking, we do also have, but it's only in Romanian, the course on HRT and cancer patients. It's also a brief course just on HRT and cancer patients for those of you who speak Romanian. We do have a course. It's also a bonus course, I think, for the beginners course in the Romanian version, but it can be purchased as well as a standalone course. Okay, so I think that's it.
I sent you some more messages on your WhatsApp. Do you see it?
So no, yes. There are screenshots, right?
Yes, I sent you
Okay.
screenshots, yeah, of the questions.
Okay.
There are some
So
more clinical cases there.
yes. Let me see where. Oh, there are a lot. How long should we still answer? 10 more minutes. Is it
yes,
okay?
yes.
10 more minutes. I don't think we will be able to answer all, but I'm doing my best. Let me see where I am so that they are answered chronologically.
Please check your WhatsApp.
Okay, I will look now.
Okay, so there's another series of messages. Now I see. Okay, so is the term bioidentical used for compounded? I have answered this question. I will try not to repeat the same answers. Why is the routine testing of estrogen metabolites not recommended in the management of HRT? It is not recommended because, first of all, it's not a cheap investigation. Of course, it is a very good, a very safe investigation if the patient wants to do it. But after several years of HRT, it is mostly recommended because then the risk starts to accumulate. But nevertheless, there are patients who want to do it even before starting HRT. So see, this is an option. It's just a price limit, let's say. Why are the dosages? One would start testosterone in menopause with blood work first or start on lowest dose? No, do blood work, as I have told you. What is your point of view to prescribe HRT estradiol included in patients with breast cancer, E receptor positive? This is not my opinion. My opinion doesn't really count. This is a formal absolute contraindication right now, at least during the first 5 years after the treatment of the breast cancer. Even the estrogen negative or triple negative breast cancer is considered an absolute contraindication as per the guidelines. How long can one offer HRT after menopause? Like I said, lifelong. How do you give progesterone root dosage and continuous or cyclical in first two cases of you discussed? in 47-year-olds. The two cases we discussed in the webinar, I have given them continuous. In menopause, definitely you give continuous, but in perimenopause, you can give cyclical or continuous. But due to the fact that this patient had insomnia and anxiety, I choose to give it continuously to help her with that, with these symptoms through the entire month, not only 2 weeks per month. What are the ranges of estrogen, progesterone, testosterone for menopausal women? This you can see on the lab references, which are given by the lab while testing. Please share literature references for testosterone and bones health. They are some references, but we stick to the guidelines. So there are a lot of studies, but the best are the guidelines, which are basically summarizing the studies, and these are the ones you can rely on, because in the studies you can find pro and cons. So the best way to address HRT issue, also while communicating with your patient, is stick to the guidelines, and you will be given in each course actual guidelines you can stick to in terms of HRT.
By the way, I want to congratulate the first doctors that already purchased the course, Dr. Sarah and Dr. Wafa. See you online soon. Congrats.
Thank you. In patients without uterus, can be prescribed progesterone for neuro and other symptoms? Definitely. I like to do that. Always. Almost always. When is the best time to start HRT in menopausal patients? As early as possible, even in perimenopause, but as early as possible in menopause. What would you recommend to health professionals who are not gynecologists but are still treating women with HRT? What should we do regarding clinical examination and follow-up when the gynecologist does not want to start to follow up on HRT, asking as an endocrinologist? It's no problem, because you will be the expert in HRT, so you will monitor, you will prescribe and monitor the HRT. It's just like another specialty where you would send the patient just for the regular checkup to the gynecologist. He doesn't even need to know that the patient is on HRT. He just needs to do a pap smear, a transvaginal ultrasound, and a breast ultrasound if he's doing so, and send the patient to a mammogram as well. This is the minimum you can do. It's like you will send the patient to the cardiologist if she's having arterial blood pressure, or to the nutrition medicine if she has diabetes, and so on. It's just another specialist helping you to evaluate the patient, assess the patient before starting on HRT. And it is you that has done the courses and has knowledge about HRT who can further monitor her HRT. So it's no problem to interact in this regards with the gynecologist. Okay. What would be considered the optimal menopause hormone therapy regimen? A 53-year-old woman postmenopausal with multiple. This is repeating. So this is repeating. Then which time of period is the accurate time to test the different hormones? I said in the luteal phase. Can you guide briefly how to manage the 4 cases you mentioned, as they are all different from one another? Oh, that's difficult now. I'm sorry, I will not answer this question because it's probably too difficult to recap the cases now. Do you have literature you can recommend to gain a good review of HRT in menopause? There are the guidelines, yes, the guidelines, and nevertheless, each guideline has a focus. So you cannot expect to learn HRT from the guidelines. You cannot learn HRT from A to Z from the guidelines. They are just guidelines. In order to learn HRT from A to Z, you really need to take a course in HRT. And without modesty, I can say our courses are really good, very complex courses, and they cover really everything you need in your practice, because they are done from experience. Above the experience, I have put the guidelines, so they are really very comprehensive and very clear, very practical. And this is how you can learn HRT, not from studies, not from guidelines. Okay, now then lower progesterone is expected in women in late 40s, so is symptom response the aim because no one knows optimum levels for any woman. Yes, symptoms can guide you a lot in these women. That's correct. In the luteal phase, some women have symptoms like in menopause because of low estrogens and progesterone, even if it is normal in a woman life. Yes, it's like the other doctors are telling you, you're in menopause, you need to suffer. It's no problem. But in these women, where's the quality of life is a disaster. That's true, and can be prescribed low dose of HRT. Yes, definitely. In luteal, if she did not want trials anymore. Yeah, sure. Besides, if you prescribe HRT like progesterone in luteal phase in these women, they are not even contraceptive. So they're not, that's not a problem. You need to ask her if they want contraception as well, because HRT is not contraceptive, it's not protective. Endometrial thickness follow-up, how frequently measured and up to how much is acceptable. This is also part of the monitoring. Yes, if you can monitor it every 3 months, every 6 months, every year, depending on your patient, on what the specific risk of your patient is. And also the cutoff. Cutoff is also in the literature. You have a cutoff like of 4 millimeters, for example, but you can go even beyond that if the patient is asymptomatic or if she's bleeding. You can even assess her with a lower thickness of the estrogen. So everything's really very personalized. I'm 47 and 4 months ago, while still having Mirena, but needed to take it out, starting having bone, muscle, joint, and tendon pain, brain fog, sleep issues, occasional hot flashes, low energy, weight gain. This is an entire list. Just did my labs, FSH 60, LH 39, progesterone 1, testosterone 1.4, beta estradiol. In testosterone, it's very important what unit it is, because there are different reference ranges for testosterone, which you can value, assess, but it's very important what unit it is. Beta estradiol 63, Mirena taken out 3 weeks ago. Okay, but probably these symptoms would have occurred sooner or later, even with Mirena, because they are also kind of estrogen deficiency. I would not rely 100% of this estrogen of 63, because in your age, this estrogen can fluctuate. So maybe if you would evaluate your estrogen in 2 days, for example, it could be as low as 20. It's not reliable, but the symptoms are maybe more conclusive of estrogen deficiency. So maybe it would make sense for you to already start with kind of optimization, both HRT and both estrogen and progesterone. What about natural products, especially if the risk of HRT is high? A natural product in terms of phytoestrogens are only palliative, alleviate only the tip of the iceberg symptoms. They are not working on prevention. Postmenopausal 9 years, no symptoms of brain fog, sexually active, doing well, exercising and maintaining weight, no brain fog. Does she need HRT? So she is postmenopausal 9 years. Well, as per guidelines, as per primary indications, she would not need. You might be maybe doing a DEXA scan to see maybe if she has osteopenia, because one of the primary indications of HRT is prevention of osteoporosis. So this could be an indication. Otherwise, if she doesn't want, it's not necessary. But cardiovascular evaluation after 9 years of menopause is also very important. You said HRT is lifelong treatment. How long do you recommend, and what will make you stop the treatment? So I would recommend it lifelong, with, of course, adjusting doses like every 2-3 years. And interruption is only if the patient wants to, or if something occurs like major events or major pathology, which are considered really absolute contraindication, and which impose interruption of the treatment. Otherwise, I would not interrupt it. Does non-hormonal alternative work? Yes, it works on symptoms. Very good. Though it does not work on the background, like cardiovascular, bone, cognitive, it will not work. But on symptoms, it will work. They are very efficient. What about the bioidentical compounded hormones regulation, dose precision? I'm sorry, this is a long discussion. This is a whole module in the course. It's not that it is in the course, but we would really need 1 hour to explain this now. Here, if the patient is 49 years old, weighs 60 kilo, 170 centimeter, has an intact uterus, and still experiences menstrual cycles, although they had become irregular, her periods last approximately 3 days with light bleeding, current symptoms. Oh, this is a long case. Oh, okay. What HRT? Oh, there are a lot of questions. This is a nice case to be evaluated in the question and answer session. But if you present such cases, which are 2 pages long, please keep into account to bring also or to upload somewhere medical documents before the discussion, because it should not be a general discussion. It would be really an applied discussion on your patient, on her lab tests, on her clinical picture. Okay, and then patient primary amenorrhea until the age of 18, then only gets periods when taking OCP, now 35 years old and has history of DVT and PE. Would you recommend that she receive HRT? Normally she would, if you diagnose primary ovarian insufficiency in her, she would need HRT. DVT must be assessed, when it was, how it was it spontaneous, was it provoked? This is a discussion of risk stratification in terms of DVT. We do have a table in which we know exactly what form of DVT is eligible with HRT. She had also pulmonary embolism, so this needs to be addressed in terms of how long it was and the circumstances, and then see maybe. But as a primary ovarian insufficiency case, she would need HRT, but I'm not sure she would be eligible even with transdermal. That needs to be clarified. I need more details about her history. I would like to confirm whether the certifications are accredited in Europe and Switzerland. It's very important to know, please. So you would get CME points. CME points, as far as I know, you need only in the European Union. In Switzerland, you don't need CME points. You need other Fortbildung, other medical education courses to fulfilled, but no CME, classical CME, which are provided in Europe. And it depends also on where you are working. If you are working in a hospital or you have your private practice, this depends. So it's not so strict.
So I think doctors actually ask if the points are only for Romanian doctors or from anyone. There are international European points that you can convert even to other places. For example, you can convert in Dubai or other places depending on the country. So there are, you have international points from the American Association and from the European Association.
Right.
We have from the European Association, and you can convert them to your country's CME points after you submit your diploma and things like this. So it's not from Romania, but it's from the European. But you will get the points when we finish this in November, because actually, so you'll have the all advanced, and then you'll have the mentorship. So each month for 5 months. So in November, all the doctors that will finish from now until November will get the CME points in November, because then we will have like a certification, you will have a test and a discussion with Dr. Raluca, and then you will get this point. So you'll not get it now, but you'll have it. It's a program. Actually, this is not a course, it's a master class. It's a program, a mentorship program. And this is why it is the only one like this. It's very different because it's not like here is a course, you learn it and then goodbye and take care and you have your own patients. No, this is a community as well. So you learn the things, then we meet and we discuss the clinical cases, then you can put questions, then maybe tomorrow you'll have a complex case in your clinic and you don't know what to do, and you have this patient with that is breast cancer survivor and has thrombophilia and has endometriosis surgery and has premature ovarian insufficiency and has some hypertension and obesity, and you want to ask what you should do with this patient, and you have Dr. Raluca and you have the community with you to discuss your complex cases. So this is like a mentorship program, and the CME points you will get in November. Okay.
Yeah, okay. So we have here more questions like indication of HRT in Turner syndrome patient. I have a Turner syndrome patient actually. I am following her for a couple of years now. You need to treat this patient very complex, but first things first, she's a primary ovarian insufficiency patient, and she needs high doses of estradiol, but other hormones as well. And they are prone to osteoporosis, so this needs to be addressed up front. And then in renal transplant patients, okay, this also needs to be assessed individually. Okay, thank you very much. Was very challenging for me as well. I hope you've received a ton of value today, and I hope you shifted a bit your mindset, because this was the scope of the webinar, to shift your mindset, to open your mind in terms of this very refined niche you can build in your practice with your expertise. And keep in mind that there are not a lot of experts in the world in this field. So thank you for participating.
Yes, thank you everyone. See you for the course. You still have time to register for the course, and see you online to discuss the clinical cases. Okay, it was very informative. What else? Thank you. Yes, thank you as well. I am here now in Istanbul as well, because I'm a speaker at a congress, an international congress here. So we are really all over the world. Okay, congrats for this excellent webinar. Thank you so much, doctors. We are happy that this is helpful for you, and see you next time. Stay close. By the way, we will have diplomas for the webinar. So diplomas are without CME points, okay? For the webinar, for this webinar today. I will give you in the group our contact, Miriam. So you can write to her if you want a certificate for participating on this webinar today. And as well, I will really appreciate if you would answer some questionnaire about the webinar. We will really appreciate that, because we want every time to do more and better for our colleagues, to help our patients together and to learn from each other. Okay, so we really appreciate if you could answer. It's a 2 minutes questionnaire about the webinar. Thank you so much. Have a lovely evening and see you next time.
Bye.
Bye.
Thank you.